All right, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our topic, we're going to be talking about recognizing and co-managing surgical complication with effective strategies for optimal patient outcome. And our speakers are Doctors Lindsey Bull and Walt Whitley. Dr. Bull received her optometric degree at Northeastern State University, Oklahoma College of Optometry. She also completed an ocular disease and refractive surgery residency at Eye Care Associates of South Tulsa, where she currently practices and serves as a residency supervisor. She's a fellow of the American Academy of Optometry and serves as a district director for the Oklahoma Association of Optometric Physicians. Now, Dr. Walt Whitley serves as Director of Professional Relations and Education at Virginia Eye Consultants in Norfolk, Virginia. He's also Regional Medical Director for Eye Care Partners. He's a past chair of the American Academy of Optometry Anterior Segment Section, past president of the Virginia Optometric Association, where he has been recognized as a Young Optometrist of the Year in 2012, the 2015 Legislative Key Person of the Year, and in 2020, the Optometrist of the Year. We're really happy to have him. I want to thank both of them for taking their time and expertise to educate our audience. So, Lindsey and Walt, please take it away.
Thank you so much for those introductions, and hello everyone. We're so excited to be with you tonight talking about co-managing surgical complications, which some of us probably have more experience in than others, but hopefully after this lecture we'll all kind of be on the same page on how we want to manage these patients, what we should do when we see these patients, when we should hold on to these patients versus refer out, and what we as optometrists can do with these patients and how we can manage their complications successfully. And so give me just a second here because my screen is not, there we go. So we have a couple of financial disclosures here, both for Walt and I. So I'll leave that up here for a moment.
And they've all, go back.
Oh, go ahead.
They've all been mitigated. And if you mention any products, there won't be any commercial bias and claims of superiority.
All right. And so when we're looking at optometric co-management, really the thing that we really want to be focusing on is how can we continue to provide high quality eye care that's extending from whatever surgery that these patients have had. How can we manage these conditions? Where do we need to intervene versus where do we need to get them back to the surgeon? And how can we do that conveniently, efficiently, cost effectively for these patients? And how can we utilize the skills that we have depending on what states that we're living in? Because we all know that depending on what state you're living in, those skills and the things that we're allowed to do may differ from one another. Do you have anything to add to that, Walt?
No.
All right. And so communication is really key to successful collaborative care. And that goes both for pre and post-operative patient care. You know, I work at a referral center where we're getting a lot of patients sent in to us that we've never seen before. And so getting the patient exams, the recommendations from the physician that previously has seen them, previously an established relationship with them, is really, really helpful for our recommendations as far as surgically, but then also managing that patient post-operatively. So all communication, I think both pre and post-operatively, can be really, really important to making sure that our patient is having the best outcome, but also the best care as well.
It's actually, I'll chime in, especially in this day and age of all these multifocal IOLs, toric IOLs. We know that we make our recommendations, but we know we may have some very persistent patients that want the best of the best, no matter what it costs, even though they're not a great candidate for it. And so, ensuring that your surgical team saw those notes, saw your recommendation. I recommend a toric lens, due to patient lifestyle or whatever it may be. And then, if by chance somehow they talk the surgeon into a multifocal and they're a type A plus or a triple plus patient, we know that that's not that patient that needs one. And so just reaching out to your center and just having those discussions on the pre-op end and the post-op end. I just got an email from one of our referring doctors that says, hey, I know I send a lot of patients to y'all, and I make my recommendations. Typically, you guys are really good at getting my patients. I like to do the 1 day post-op, 1 week, whatever it may be. But how can we improve how we keep track of those patients? Because He doesn't want to drop the ball. We don't want to drop the ball. And just so finding ways that we can address that together. But that's all I was going to add to that.
Yeah, I actually had a patient experience yesterday. I was doing a cataract evaluation for a patient that was referred into our office, and the chart note said this patient would be a candidate for either a basic or a toric IOL, but please do not put a multifocal lens in this patient. Those notes are so helpful to us when we're, making our recommendations and how we lead that conversation with the patient as well. And so I think this first case is yours, Walt, so I'm going to let you get after it.
Yeah, and so we've seen a case like this, patient cataract, referred for cataract evaluation, blurred vision. You can see the various cataracts there. I mean, the one on the left one, Lindsey, is the right eye. What would you grade that cataract?
I would grade that as probably like a 3 to 4 plus NS.
Yeah, and so we see that cataract, 3+ cataract should be 20/40, 20/50 at the worst. Or, we look at the one on the right. Is that even a 1+ cataract? But we know 1+ should still get to 20/20, 20/25 at the most. Maybe there's some cortical, maybe there's some PSC in there. But looking at those cataracts, they may make sense. The reason why we have this up here is because sometimes we see patients that have both cataracts look exactly like the image on the right, so maybe 1+ cataract, but we may get that patient that has 20/50 vision. And so it's always important to make sure that the cataract makes sense. If it doesn't, take the next step, order your OCT, do your visual field, or whatever it may be. Next slide. And so the patient had uneventful cataract surgery, and 1 month after surgery, OD called and said, hey, I'm seeing the patient has decreased vision. At 1 week, it was 20/20. Now it's about 20/40. I'm not seeing any appreciable inflammation or swelling, but can I send that patient back to you all? The OD didn't have an OCT at that time. And so I said, of course. And I said, to get this patient just restarted on steroids and non-steroidals, because likely 1 month after surgery, what do we think he's going to have? CME. And so just want to get that going until we saw him for the OCT. You can go to the next slide. And so patient came in, vision was blurry when I saw the patient 20/40 minus. But when we look at the slit lamp, had 2+ SPK, which dryness, I know you do a lot of dry eye, Lindsey, as well.
I do, yeah.
I mean, we know 2+ SPK can lead to 20/30, 20/40 vision. And so is that the reason for the decreased vision? Is it the 1+ PCO, or did that patient have macular edema? If you go to the next slide, this looks at the most common complications. And number one, it's going to be ocular surface disease is what we're going to see after surgery, even after 1 month. CME, I know this says up to 12%, but in the more recent literature, it's about 1 to 3% of patients that have it. We know what PCO looks like. We know what the corneal edema looks like. Vitreous prolapse. Lindsey, what do you do for patients if you see that vitreous prolapse? What's your surgeon going to do if you send it back to him at one month?
He's probably not going to do a whole lot at the 1 month. He's probably just going to want us to monitor it unless there's some adherence of that vitreous to the wound on the cornea or some kind of retinal traction that we're seeing on the inside of the eye. Then obviously they're going to intervene a little bit quicker. But for just a mild case of vitreal prolapse, we're probably just going to monitor that.
But you're in a laser state. Is that something you're having that surgeon do, or are you doing that?
It's
adherence to the wound.
If there's adherence to the wound, it is something that we can do. And so that is one of the things that we will look at and determine how much we think it's affecting the patient's vision and whether we think that's going to be beneficial for the patient or not. But we could take a YAG laser and try to zap that if we felt like it was necessary.
And so this patient did have CME, and as I mentioned, all the other findings they had. Next slide. And so the treatment in our practice, so I work at a tertiary referral care practice, and we have the cornea, retina, ocular, we have all the specialists there. And so having that discussion with our team is how do they want to address this? And so what we came up with as a group, we always go with diflurprednate. We know it's 4 to 5 times stronger than brand Predforte, so it's more potent. Yes, with more potency, we may get increased pressure. However, the sequelae of inflammation is a lot worse than the pressure, because we could always treat the pressure. The patient has a pressure response. And so this is what we go with, as well as a patient on some type of non-steroidal. And so we chose Bromfenac, but oftentimes that may be expensive. I actually had a patient today. I saw him a month ago. At 1 month, his thickness was like 612. And I put him on the diflurprednate. I did put on ketorolac. He never got the ketorolac. He was down to like 313 today, just on the steroid alone. And so it is potent, but it did improve the patient's vision. So in our practice, the retina doctors, what they want is they say, hey, put them on the drop, see them back in a month later. If it's better, great. If it's the same or a little bit better, keep them on the drops. If it's worse, send them back. How do you do it? Are you sending it back to your surgeon? Are you getting retina involved? How's that work in your practice? Or are you, Greg and Joe, if you want to chime in?
Yeah, so we're doing it exactly the same as you. Our drop schedule is exactly the same as well. We're seeing them back at 1 month, looking for, and oftentimes not complete resolution, but at least a little bit of resolution. As long as there's a little bit of resolution, we know that our process is working. We're going to continue to follow that up. If we're seeing no resolution, then yes, that's the time that we're getting either the surgeon involved or potentially retina involved.
Yeah, I treat them in the practice. I follow them and pretty much the same thing. 30 years experience doing post-operative care. If it's not responding, my surgeon will just say, send it over the retina because he's going to be like, what can he do different than me? So we just send him the retina.
Yeah, same here.
You can go to the next slide. And actually, I just mentioned this. Typically, CME happens at 4 to 6 weeks, but the incidence is low at 1 to 3%. But if you go to the next slide, if we look at the risk factors, and so several years ago, we used to think that all of our patients were on brand medication. We're like, oh, you're on brand medication, best outcomes, or it reduces inflammation, and then we started noticing, like, we'd say, yes, they'll get the brand antibiotic, they'll get a generic steroid, they get a brand a non-steroidal, and different combinations of that. And so we actually did a study, internal study. We looked at all of our patients that had CME in the last year. And what we found is it had nothing to do with brand versus generic. It had to do with this slide right here. If they had any pre-existing ocular inflammation, any retina compromise, those are patients that end up getting CME more than anyone. In our practice, we put everybody on a non-steroidal. We use combination drops. Even though it's 1 to 3%, we want to minimize that risk for any patients. And I think you do the same. Is that right, Lindsey?
Yes, we'll either do combination drops or we do dropless cataract surgery, which we'll talk about in a couple slides here.
You go to the next slide. Or you can mention this already. You go to the next slide. And so operative complications, going back to the communication, if your surgeon has a complication, yes, that can occur. And hopefully they called you and let you know, but sometimes they may not have. And then the patient's going to call you, and then you're going to have egg on your face. You're like, I have no idea what happened. They're going to say, I thought you talked to the surgeon. And so just making sure if something like happens like this once, they probably meant to contact you. But if you're seeing this and they didn't contact you, you need to have that conversation, because that is not collaboration. That's not co-management. Here's an example of a patient on Flomax. And so if they've ever been on Flomax, essentially let our surgeons know, or your surgeons know, they'll either have this Malugan ring or iris hooks ready for the patient to ensure adequate dilation. Although more commonly what they're using is a drug that has a combination of phenylephrine and ketorolac to help prevent intraoperative meiosis. And so, but that communication, even from the surgeon, is just as important. Or let's say you typically do a one day post-op and something happened during surgery, then that surgeon's going to see that patient that next day, but letting you know why that happened, because the patient does need to be also cleared after that surgery if something did happen. Any comments on that, Lindsey?
No, I think that was great. And yeah, I agree, because we're seeing a lot of times, if there happens to be a complication with one of the patients that one of our surgeons is doing, we will make that call, or have our surgery counselors make that call to just let the referring doctor know, hey, this is what happened. We'd like to see them one day post-op instead of you. Is that okay? Making sure that they're just aware, I think, is part of that collaborative care that's so important for the patient outcome, really.
Yeah. And it comes down to, first, with co-management, patient choice. But then how did the surgery go?
Exactly.
Who should that patient be with? So you can go to the next slide. So here's one of our polling questions. So what is a common treatment for mild post-op wound leak? A, oral steroids, B, oral antibiotics, C, sutures, or D, bandage contact lens?
Okay, the poll is open. So, well, you might want to chat a little bit more. I mean, I know we do it all the time. I have a complications where I talk about flow max. We always want to warn, but I think you kind of talked a little bit about, patient takes a flow max and they're off of it for 2 years. They still have floppy iris. So
Correct.
that's why, you might want to just talk a little bit about, I guess what are they? Alpha agonists, I think is what they are, and why we want to warn our surgeons. Hitrin's one of them. Flomax is another. Again, being a part of that team, I mean, we just talked about the iris being flaccid, but what's the other issues that are out there?
I mean that's going to be the biggest issue. If the patient has ever been on Flomax, currently or ever on, this is something that can occur. And you mentioned the alpha agonist, and so during surgery, that is like a wrestling match for that surgeon if we don't have that adequate dilation. So that way they have their surgical team ready with whatever instrumentation or with any injections that they may need.
And I'd like to bring up that so often we think about Flomax just for our male patients, but it actually is a very, very common treatment for kidney stones as well, which females do also get. So make sure you're not just asking that question to your male patients, but you're also asking to your female patients for that risk. If they've had kidney stones in the past, that's probably something that they've used to treat their kidney stones.
You guys will, and I'll give you the answer here to the polling question, is that you'll like this complication is that, I've learned to burp paracentesis, and this is a two-way street. We want to warn the surgeon, but I ended up doing a couple 1 days for the guys that didn't want to do them in the area, and they didn't tell me the patient was on Flomax. Patient came in with a pressure of 50 some. I burped the paracentesis, and along with it, out the paracentesis came the iris wound,
Iris.
came the iris. So I had to call him up. He's like, "Oh yeah, I forgot to tell you. Might be high. I left a little vasculoelastic in there." And they had, so I had to send it over. He was lucky it was in the operating room and pushed that wound back, the iris back out of that wound. But it's a two-way street when you're talking about communication. So,
Absolutely.
all right. So here's your polling question. Oral steroids, 3%, oral antibiotics, 14%, sutures, 20%, and then 65% went with a bandage contact lens.
What do you think, Lindsay? How do we treat that?
So for a mild post-op wound link, I'm going bandage contact lens all day. If it's more significant than mild, that's when I'm potentially getting my sutures involved.
Yeah, exactly. And so once again, with that wound leak, if you're going to have low pressure, if you're having that leak, you may have or you're likely going to have a shallow anterior chamber as well. When you're testing for the Seidel, getting your fluorescein strip and painting that wound, the fluorescein strip, and then you'll see it come out. So it's not just putting the fluorescein in the eye; it is painting that wound where you're concerned, but then seeing what is coming out. If it's slow, as Lindsay mentioned, bandage lens. Or if it's going out quickly, then you want to get those sutures involved. But you can go to the next slide.
And typically, if it's a slow leak, you put that bandage contact lens on. I'm usually, and you're probably the same way, correct me if I'm wrong, I'm taking that bandage contact lens off in like 24 to 48 hours. So it's not something that I'm keeping on for a significant period of time, just to apply a little bit of pressure to that wound to have some adherence of that wound there. And then we're just removing that usually the next day.
And one thing to add is anytime you do deviate from what's a normal post-op, you need to see that patient sooner. So that's not going to be a week. This is where you'll see that patient the next day, recheck it to make sure that the leak did stop.
Exactly.
Well, let me make one comment, and I'm going to let you guys rock and roll. When you say paint the wound, what I wanted the audience to know is that you got the patient behind the microscope, you have your fluorescein sodium, and where you think that leak is, you're painting it and looking for it. Meaning, I see a lot of people, a lot of the colleagues, what they'll do is they're painting it, and then, then they get the patient behind the microscope, and then they kind of look at it. It's already gone by then.
Yes.
So what Walt is telling everyone is that you got to have that patient behind the microscope, think where the leak is, have everything turned on, your Ratten filter, and paint, and then you'll see that move immediately. By the time you get them back in position, you missed the opportunity.
And to make it easy, it's typically going to be on the left eye. It's going to be at 3 o'clock with the main incision. For the right eye, it's going to be at 9 o'clock for that main incision. So you're gonna take that strip and go along that incision. That's where you'd see that leak.
Absolutely. All right.
And so we mentioned some of this already, the CME, PCO. We'll talk about that shortly, but endophthalmitis. And so if you're doing the 1 day post-op or even the 1 week post-op, if a patient calls with decreased vision or pain, typically 3 to 5 days is when endophthalmitis happens, and that is a surgical emergency. And so you need to see that patient right away, or they need to see someone right away. But if we're co-managing that patient, then we're the ones that need to see that patient, looking for what the vision is, seeing how much inflammation is in the eye, and getting that surgeon involved as well. Or we have a case that will come up and talk about that. But
We will. Yeah.
next
A
slide here.
complicated case for that too.
So 20 unhappy. I mean, here's some of the various ones that you can see post-operatively. I'll let you comment, Lindsey.
Yeah, so I think, 20 unhappy really could mean any of these things, and a lot of times a combination of these things too. But when you're looking at patients who especially have paid a significant amount of money to upgrade to premium IOLs, I think it's really, really important that we're looking to make sure that that IOL is actually functioning for that patient as it's supposed to. And so diagnosing, making sure that we're treating all of these things before that lens becomes too scarred in the eye, before any changes happen that we can now not reverse. And so making sure that we're looking for that PCO. And if it is a multifocal IOL, is it really the PCO that's bothering them, or are they just not adapting to that lens, and trying to determine how we figure that out for that patient so that we can make sure that we're taking the next best appropriate steps, because there are a category of patients who will not adapt to those lenses. And we need to make sure that we're having the appropriate conversations to make sure that it's not the PCO, that it is just that they're not adapting. I think dryness is by far and large the most common thing that we're going to see with any post-operative complication, whether it be with cataract surgery, with refractive surgeries. But you can pretty much assume that every patient that you're going to see who has had intraocular surgery or an ocular surgery is going to be dry for a certain period of time afterwards. So at our practice, we're managing dryness on every single patient who is coming in, regardless of whether it's a complaint or not, pre-operatively, so that we can make sure it's not a complication post-operatively. And I think that's really important when you're looking at surgical outcomes and how happy the patient is going to be with whatever selection they picked.
Yeah.
Lindsey, would you agree that's more of a toxicity rather than dryness? I mean, betadine's been beating the heck out of it. They have a lid speculum in, they're staring into a light. There's, a surgical technician wetting that. Isn't it more of a toxicity rather than dryness?
I think it's probably a combination of both things. If you're looking at, the 1 day to the 1 week, I think it probably leans more to that toxicity. But if you're getting 3 months out and that eye is still really, really dry and looking beat up, is this a patient who just has dry eye that we need to be managing to make sure that their post-operative care is effective for them? So I think it probably differs a little bit between patient to patient, but definitely within that, if I'm seeing somebody back at a 1 day post-cataract surgery and they've got diffuse SPK across the cornea, that for sure is going to be due to whatever betadine or iodine substance was used on that eye surgically to try to avoid endophthalmitis risk.
And where that dry eye and refractive error overlap after surgery is, if you see dryness, actually always suspect dryness first. Put them on the lubricant. If they're probably already on one, put on some type of immunomodulator. Do something for the dryness. Bring them back. Check that refractive error. Once you get consistent refractive error, then that's what what the residual refractive error is. And if a patient needs an enhancement, let's say we're talking about a toric lens, then we get them back to the surgeon saying we address the dryness. We have a stable refractive error. There's also been cases that we've seen for patients that have astigmatism. If that patient after surgery has any cross sill, right? These are toric lenses, they are very precise. And even the liberal relaxing incisions that are not as good, I don't think, in my opinion, as the toric ones. However, they should have very little astigmatism if we're addressing that. So we'll never tell a patient the toric lens didn't work. So if you have that cross sill, you need to dilate that patient, look to see where those axis markers are. If the surgeon used a femtosecond laser, some of the newer ones that can put a little tag at the target axis on the capsulotomy, so you'll know where the target axis is supposed to be. If not, if they don't tell you and you can't see that, look at the steep Ks, and whatever that number is, that orientation for the steep K, that should be where those toric axis markers are. If you have, let's say, +1 cil or -1 cil after the surgery, most likely that rotated, and the patient may need to be sent back to the surgeon for them to orient that toric lens back into place.
Mhm. And usually those rotations are fairly easy for the surgeon to do as long as they're getting them back in a specific period of time where that capsule hasn't, shrink wrapped around that lens too much. It can usually rotate pretty easy. So the sooner that any rotation of a toric lens can be caught, in my opinion, the better, so that it doesn't risk tearing the bag as they do that rotation.
And then Lindsey mentioned the PCO and the multifocal lenses. And just to reiterate, if that patient was happy at 1 week or 1 day, 1 week, and 1 month, and then it started getting blurrier, then we know it's the PCO. But if they were never happy at 1 day, never happy at 1 week, never happy at 1 month, do not do a YAG on them, because once you do that YAG, it is extremely difficult to do an IOL exchange, and even more difficult to find a surgeon that will do that IOL exchange on that patient. And so that patient's to be left with, it is what it is after that. We had a case on that, but we just addressed that case, so that's okay.
Perfect. All right, you ready for the next slide?
We can do it.
All right.
So here's a patient, 85-year-old white female, referred for blurry vision and reported she went to her OD. She fell a week ago and says, "Oh, everything seems to be blurry." Reports redness inside the eye. Had surgery about 6 years prior, dry AMD, and you can see the medications and the history as well. You can go to the next slide. And so 20/70 in the right, actually in both eyes, but you can see the pinhole as well. But oh, look, this is a photo courtesy of Greg Caldwell. Thank you, Greg Caldwell. But here we can see, look at that implant, and what is going on behind the IOL, and where is that posterior capsule. And so looking at this cloudy appearance, this is something that once you see it, you're like, man, I may have missed this several times in the past. Patient just may have been complaining about it, because sometimes it can be so subtle for the patients and we may miss it. But and so we see that cloudiness in there. You go to the next slide. And then so here, here we see the implant. Here we can see a patient that has a typical posterior capsule. There's a little bit of fibrosis on that, but you can go to the next slide. And so this patient had capsular bag distension syndrome. And so the question is, how do we treat that? And so what is that cloudiness that is behind the implant and anterior to the posterior capsule? Do we do it with a YAG capsulotomy, posterior capsulotomy, B, topical steroids, C, vitrectomy, or D, YAG anterior capsulotomy? And so we'll go to the poll now.
Yep, poll's open.
Excellent.
We're waiting for people to roll in. Well, you might want to go back to that, or Lindsey has the control. If you can go back
Yeah.
to the, maybe to the slide before that, and just kind of point out that fluid back there behind the implant is where all that fluid's building up. If you you can use your pointer, they'll be able to see it.
Do I have a pointer?
Do I have a pointer?
Yep, it's right there.
I
Whoever
do, right
has it.
here.
Yeah, so that's, the back, you can see the front of the implant right there, and then there you can see the implant, and then there's all that fluid back there that has built up, and that's the capsular bag distension. Well, like you said, once I saw it the first time, I know I missed it before, because I had a couple patients come in and then we found it and then how to treat it. So
It's shocking. Practicing in Oklahoma, I've been lucky that I've been able to do lasers pretty much since I was being trained in school. And I think it's really surprising how often this happens and how often you don't realize it until you take your first shot with the YAG laser, how it looks different when you're shooting it. In fact, when I see this, I actually have changed the way that I do my YAG capsulotomies on patients who have this versus patients who just have your typical PCOs, where I typically am making a cruciate pattern going from top to bottom and then side to side. With these patients, I will actually go from bottom to top, because what ends up happening is when you're making that opening, it kind of comes off like a sludge. So if you start at the top and go down, you'll almost start to miss where you need to be shooting that laser, because all of that fluid and all of that sludge is just really minimizing the way that the Heine beams on the laser are able to meet and are able to focus. And so when I see these types of patients, I've totally flipped the way that I do my YAGs on these patients to make it more effective.
That's a great clinical pearl. So let me display the answer here. And we have 54% going with YAG cap, steroids 12%, vitrectomy 14%, and anterior YAG capsulotomy was 20%.
Yeah. And so,
So the winner was 54 with the posterior YAG, and pretty much 20% across the board for the other ones.
okay.
Perfect.
Talk about capsular distension syndrome. I mean, it's going to say rare on the next slide, but once you see it, you'll see it more. It's a fluid accumulation between the lens and the posterior capsule from those lens epithelial cells, and it just becomes milky over time. You may get a myopic shift, and our patient did have that. But here you can see the various risk factors that's in your notes. But you treat it with the posterior YAG capsulotomy for those patients. And thank you for those pearls, Lindsey, that I will use when I get to start to do my lasers here shortly.
Yeah, next week.
2 weeks. I'm in Cooperstown next week. You go to the next slide. And so the YAG capsulotomy, this is our great friend Nate Lighthizer. This is not posterior capsular distension syndrome, but this is just doing a YAG capsulotomy. Right now, what are we up to? 13, 14 states that are doing these procedures now. And you can speak to this since you do it all the time, Lindsey.
Yeah. So what he's
Point
doing.
out the Heine laser there with your pointer there.
Oh yeah,
Lindsey.
so the Heine laser here is going to be the red beam that you see here, and sometimes you'll get a couple of kind of diffraction points there where it shadows almost. But really, depending on what type of laser that you use, it's either going to be 4 Heine beams or 2 Heine beams that you're going to just allow to bring into focus, where they meet all in the middle as one on the surface that you're wanting to treat. There's lots of different ways that you can do YAG capsulotomies, but I think by far and large, the most common way is to do what Nate's doing in this video and doing just that cruciate pattern that I was talking about, where you're making a cross going from top to bottom and then side to side. Depending on how thick that PCO is really going to determine how many shots are going to need to be taken with the YAG laser. Typically, we're starting around anywhere from like 1.6 to 1.8 millijoules per shot, and we can turn that beam or that power up or down depending on how much reaction we're getting and how much opening of the tissue that we're getting as we're taking those shots. I've had some that I think are going to take 40 shots and I end up taking 13 shots and the thing is completely open. I've had some that I'm like, this is going to be easy, and then 40 shots later, we're still firing at it. And so it's different for every single person, and really you're just looking at how that tissue responds and where you need to adjust your power based on that response.
Perfect. Thank you.
All right.
And throughout, if you have any questions, don't forget to put them in the chat box, and then Joe and Greg, they'll help monitor that for us. I'm going to skip through this case, but this is that case that we just spoke about, the multifocal patient with a PCO. This patient was, whether they have to be happy at 1 day, 1 week, and 1 month if we're going to do a YAG capsulotomy for those reasons I mentioned. The IOL exchange is impossible, if not extremely difficult to do. One of my partners had to do one recently, and he he was very tight throughout the procedure, but he said he did it successfully. But most surgeons don't want to do that. You can go to the next slide. But for most patients, it's all about neuroadaptation, and some people do it within a month. Some people are 3 months. Anytime they have the multifocal IOLs, and they say, "Oh, I can't see up close," or "I can't see the intermediate." Depending on the multifocal they have, you can get minus loose lenses, give them something to read and put it in front of their eyes, and then they say, "Oh, I can't see anything." And then you reinforce, go, "Well, that is 20/20 without these lenses, and this is the benefit of you getting that multifocal lens." Well, what we're trying to say here is neuroadaptation may take up to 6 months, if not longer, for most patients. But if you're doing the post-op, making sure you ensure the patient that you're working closely with our surgeon to make sure that the patient gets those optimal outcomes, because patients want to hear that we have a plan in place to make sure we meet and exceed their expectations.
I really think that this is one of the most difficult things to understand and to capture when you're talking about patients who are unhappy with their multifocal IOLs. And so really it's going to be listening to the patient complaints of, like Walt was saying, if they've complained every day from their 1 day post-op all the way through, then I think that a neuroadaptation problem needs to be considered. If they were happy at some point during the process with their multifocal IOL, I think that that patient is more of a safe patient where you could consider doing a YAG if they have a PCO or trying to intervene in that way. But you want to make sure that you're really catching these patients before it becomes too late to exchange that IOL.
Lindsey, taking out all the neuroadaptation, you have someone that's doing well. Do you have a lower threshold to laser off a PC haze on a multifocal rather than a monofocal?
I absolutely do. And I think that when you see a lot of multifocal patients, what you'll find is that a very, very low grade PCO is going to impact them more at nighttime with glare and halo than somebody who has a monofocal IOL option. So those patients, I'm always, as long as I know it's not a neuroadaptation process, I'm always going to offer doing a YAG capsulotomy on those patients a little bit sooner and a little bit earlier than I would somebody who has a monofocal IOL.
Thank you.
All right.
So an enhancement, typically, the surgical team is going to have a plan in place. And this goes back to reassuring the patient, hey, that you had a little residual refractive error, you're this nearsighted, or you had previous LASIK. And so, you're adding one more variable to your outcomes. And so sometimes we have to go back, either do an IOL exchange or we have to do some type of laser vision correction. Typically it's PRK is what we do within our practice. But we make sure that we have a plan in place for getting those patients their optimal vision.
We also include PRK in all of our premium lens packages because a lot of these patients will also have a decent amount of ABMD too, that when you do PRK and debride that epithelial surface off, you're letting a new epithelium grow, and that can impact their vision positively as well. So ultimately, if it's significant, we're wanting to do that before we do any cataract surgery, but even a trace to a mild case can really be positively impacted by doing PRK post-operatively.
So the next couple of slides here, you can put the pictures up. Main thing I want to show patients here. And so is my pen working? If not, I don't know. If you can do the pen, if you can show that piece of the lens inside the anterior chamber. And so here's a patient 3-week post-op. I'm gonna, you can look up, everyone says, check to see, is it moving around? Is there corneal edema? Use steroids, a series of melted away. I have never found anywhere in the literature that tells me why it melts away. Any of you, Lindsey, Greg, Joe?
Not in the literature, but it does work.
Yeah, yeah. So, I mean, that's something that we do within our practice. And so we'll bump up the steroid, maybe every 3 hours, every couple hours for that patient, for a week or two. And if it doesn't go away, then we get the surgeon back involved within a couple of weeks. They're going to most likely go back in and remove that the cataract, residual cataract, to ensure that that does not cause any corneal edema. But if there's corneal edema and you see that lens particle, then you're going to want to get that surgeon involved sooner. And so just wanted to highlight that. Next slide. Sometimes you may see a patient, let's say 6 months out. And if you could put on those KPs on the lens there, Lindsey. And so you may see this like plasmoid, sticky, flat KP is essentially what it is. That's on the anterior surface of the lens. If you turn up your lights, you're going to see some cellular reaction in the anterior chamber. Here, you're treating this just like a uveitis. Bump up the steroid, put the patient on it 4 times a day. For any of our uveitis patients in our uveitic practice, our go-to once again is difluroprednate. Why we want to get rid of the inflammation as quickly as possible. When you get rid of all those KPs, get rid of the anterior chamber cells, then when you know that we have addressed the condition. And we have one more picture, I believe. And then here, anytime you have that anterior chamber IOL, you may have some patients with low-grade inflammation. And so these are patients that, they're going to be on steroids. they're going to be on, they may end up being on some type of anti-glaucoma agent to address any pressure because they're on chronic steroids. But if that inflammation doesn't get better, then you may need the surgeon to go to get involved to either reposition that lens and help or do a different type of exchange to help with this chronic inflammation.
Hey, Walt and Lindsay, before you go on, a question came in about the previous situation. Does it differ if it's cortex or nucleus?
That's
Going back to this one,
Yeah.
you want to take that one?
It's either way.
So I'm putting him on a steroid regardless, but I'm probably also getting the surgeon involved because even despite on a steroid, it may not dissolve completely and it may lead to some inflammation that we don't want to be present there. So I'm always leaving that decision up to the surgeon whether they want to go in and retrieve that lens particle or not.
Yeah,
my surgeon will take out nucleus every time. He just finds that it takes too long, and cortex can, maybe he'll sit on it for a little bit. He just would rather get that out of the anterior chamber either way. But he does have he'll ask me how big the cortex is, and and we can sit on that. But nucleus, he usually likes to get out.
Yeah, pretty much the steroids won't dissolve that, and you can get some pretty bad complications from retained nucleus.
Oh, sorry, I'm going the wrong way. Give me just a second to get back to the slide we were on. All right.
It's just a review.
All right, you ready to go on to the next one, Walt?
we're good.
All right. So I think I'm going to take over for a little while here. So we're going to get into a little bit of refractive surgery case here for a bit. So had a patient not too long ago, 47-year-old male. He comes in. We had done PRK on him the day prior. The reason we had chose to do PRK on him, he did have LASIK prior back in 2004. So our kind of way of thinking is if somebody needs an enhancement on the refractive surgery, if they're within 12 months, we can probably try to relift that flap. But if they're over that 12-month or 1-year mark, we're going to convert to PRK at that point. Relifting that flap can cause a lot of complications, a lot more glare and halo post-operatively. So you can see his prescription wasn't significant. He did refract down pretty nicely. And so he still had enough corneal tissue there where we felt it was safe to do PRK at that point. So 1 day post-op, pretty typical for where I see my post-op PRKs. Really, they can be all over the board, but he was about 20/80, 20/100. One of the things that we're always looking at is are their bandage contact lenses still in place and are they on the correct way? So we don't want a contact lens that's inside out because that's going to really impact that epithelium from healing nicely. And the way that we do all the refractive surgery PRKs is we're putting them on a fluoroquinolone 4 times a day for a week, a steroid 4 times a day on a tapering schedule over the course of that month. Bromfenac, we're going to do twice a day for a week. And then we put all of our patients on gabapentin as well, because that has been shown in studies to decrease postoperative pain after PRK. I'm doing that for some of my significant recurrent corneal erosions and those kind of things as well to help with pain. But it is scheduled in some states, so be careful of that. And then we're also prescribing at the time of the procedure 2 additional tablets of lorazepam. So they're given 1 tablet to when they arrive at our office to have the procedure. We're going to call in an additional 2 tablets for them upon leaving, just to take as needed to help them to sleep for the first 48 to 72 hours. And then lubrication drops a minimum of 4 times a day. Typically, we're doing our procedures on Thursday so that we can see them back for a 1-day post-op on Friday, and then for their bandage contact lens removal early the following week. So I was not on call this weekend, but one of my colleagues was, and he got an emergency phone call on Sunday that said that the left eye was extremely painful. So just what we love all of our PRK and post-LASIK patients to do is they start rubbing the eye. So that's exactly what this patient did. He started rubbing his eye, and because of that, the contact lens fell out. And so this is one of those patients that you're having to go in on the weekend to see them. You want to make sure that that epithelium is healing right. That bandage contact lens needs to be replaced. So anterior segment findings upon arriving at the office was sure enough that left contact lens had fallen out. The epithelium had not completely healed, so there was some loose epithelium that was noted centrally that really wasn't adhered and didn't look like it was healing super well at that point. And so at this point, what do? Do you replace the contact lens? Obviously, we're going to replace it, but what do we need to do before replacing it? What our thought process is if that tissue is no longer adhered, it's probably not going to. Just the impact of him blinking from the time that it happened to the time that he got into the office had pulled up some of that tissue. So my colleague decided he wanted to debride that loose epithelium and then put a brand new bandaged contact lens on it at that point. We're always going to document how big that epithelial defect is after we document it, so then we can very well track how it's healing over the course of the next couple of days. And so he came in for the next day. And so he was about 4 days out of the PRK. On that right eye, the epithelium was looking great. That BCL was removed at that time. The left eye, my colleague saw him again that day. He decided to take off that bandage contact lens to assess that debridement wound, and then he replaced the other contact lens. Personally, I probably would have just kept that contact lens, that same one that I had put in the day prior on, and reassessed in a couple of days. But to each their own. I probably just would have kept that one on. There are some studies that are now showing that keeping those bandage contact lenses on for a little while longer can impact a faster visual recovery for those patients. We feel like the infection is still more important, so we'd rather take the contact lens off and decrease the risk of corneal ulcers or any kind of infection happening there. So we're usually still taking it off at the 4 or 5 day mark. At this point, the patient was to continue all meds as previously prescribed. So day 6, he comes back and the defect does look about half the size of what it looked like previously, but it's still not healed completely centrally. So we were going to see him back in another 2 days. And so he comes back 2 days later and it is exactly the same size as 2 days ago. And if you think about how much corneal epithelium is supposed to heal in a 24-hour rate, you're really looking at somewhere between like 2 to 2.5 millimeters. So the fact that we had seen no epithelial growth over a 48-hour period was indication that this epithelium is not healthy at this point and we need to do something a little bit different. What we typically will do is, because fluoroquinolones can delay epithelial healing in some patients, is we'll try to switch that antibiotic. Typically, we're using something like polytrim for those patients. But you do have to think about, is this patient having an adverse reaction to BAK? They're on so many different eye drops that do have preservatives in them. Is that slowing the healing? We're always using mitomycin in our PRK patients as well. As soon as that laser is done firing, we're putting a pad of mitomycin C on the cornea to try to decrease corneal haze post-operatively, and that can sometimes allow to a delay in corneal healing as well. But the right eye we knew had healed really, really well, so we were thinking probably not that. So we switched the antibiotic, decided we were going to see him back after the weekend was over, and still that defect is exactly the same size. So at this point, you do have to increase your aggressiveness with these patients. 10 days of persistent epithelial defects is when you want to consider doing that. There are some studies coming out that are showing that with persistent epithelial defects, topical insulin seems to be working well. What we decided to do at this point was debride just the edge of that tissue, see if we could get some new epithelial cells that would grow in and adhere and meet in the middle there. And then we also decided we wanted to use an amniotic membrane. For this patient, we used a cryopreserved membrane. And so that can help to support reepithelialization as well. And then we were going to see him back in 2 days again. So he comes back, we take that amniotic membrane out, and the epithelium had grown back together. So we were really pleased with that. We did decide to replace it with another bandage contact lens for a couple of days to try to prevent a recurrent corneal erosion from happening. And then we wanted him to continue on that switched antibiotic from the polytrim just to ensure that the fluoroquinolone wasn't problematic with that delayed epithelial healing as well. We saw him back 2 to 3 days later for a BCL removal and discontinuation of that antibiotic and NSAID, and then starting that tapering of the steroid. So at 1 month, he was actually doing really, really well. It didn't delay what his visual acuity was at that 1 month period. It was just for that first week and a half there that we struggled getting that epithelium to heal completely. And so no corneal epithelial haze noted or stromal haze noted, epithelium was intact. And then we typically will see our patients back at a 3-month post-op for that, just to ensure that they're still doing good and that the dryness that they can get post-refractive surgery is well under control. So what could we have done differently in this case? when you're looking at somebody who is post-surgery and they're using so many different drops, as we said, with cataract surgery, now with refractive surgery, they're on all of these medications that typically do have preservatives in them. So in patients that have reactions to preservatives, looking for those preservative-free options, I think is really important for those patients. Potentially, we could have debrided and done an amniotic membrane a little bit sooner. Like I mentioned before, I probably wouldn't have replaced that bandage contact lens. I know Walt and I have talked about this case before, and he brought up, at one point when we talked about it, did you ever consider a herpes type of delay there? Could you have treated with an antiviral? And I think that's a really good point to make and something to consider when you have a delayed epithelial healing response. But I think, when you're in it, you just have to make whatever decision is best for the patient, best whatever you think is for the patient, how they're best going to heal. Trying to switch a lot of things at one time can really confuse on what's working versus what's not. And so I think by switching the antibiotic first, when we realized that wasn't working, moving on to plan B, I think was a really good thing for that patient. Anything to add or anything you would have done differently, Walt?
Yeah. I mean, you just mentioned what I was going to add is
Yeah.
do the same thing, but I would just add an antiviral. Typically, I go with Valcyclovir, just
Mm-hmm.
I remember 500 milligrams 3 times a day for the patient.
Yeah.
The one comment on when they moved was a 1-day post-op debridement a couple ago. If you had to debride it and you put a new lens on, typically I would just treat that like a brand new PRK patient. You mentioned this. I would wait 3 to 4 days to remove that lens. Just give it a little bit longer to re-epithelialize. And so I think that would be very important on that.
Exactly, especially without evidence of infection on the cornea. I would have left that contact lens on a little bit longer to try to promote that re-epithelialization a little bit better.
That's a really good
Can
point.
Lindsey, for those that haven't worked in surgery centers or maybe don't have the post-op, you mentioned mitomycin C,
Yeah,
as an anti-neoplastic or chemotherapeutic
yeah.
agent, and they use it sometimes for TRABs. But maybe take a little deeper dive in why you thought that maybe that could have been
So that can
why
be
you used it.
Yeah,
Go
so
ahead.
that can be toxic to the surface of the eye. But what studies have shown is that the rate of corneal haze does decrease when you use it. And so we only keep it on the surface of the eye for about 10 seconds. And we typically will soak it in a pad, just lay it on the surface of the eye immediately post the laser firing. And then we wash it off profusely to try to prevent that toxicity. But because it does have toxic effects to the surface of the eye, there is thought that potentially it could delay healing in some patients. In our opinion, the benefit of not allowing that corneal haze to develop is more so than the toxicity that it could cause on the surface of the eye.
Yeah. So for the audience that's out there, it's, delays wound healing. That's why they use it for TRABs, so that the TRAB doesn't scar down. Here they're using it for anti. But the other point, I'm glad you mentioned it, is like it's literally on there and you count it out and you pull it
Yes.
off and then you rinse. Like you
And
don't
then
want
we
to
rinse.
like walk away and have it be on there for, 5 minutes. So
No. And we were even doing 12 seconds with the mitomycin C, and we switched to 10 seconds a couple of years ago. Feel like the impact as far as not getting corneal haze on our patients was not did not develop more when we switched that timing. And so we've kept everybody at 10 seconds now. So just a couple of seconds less of having that medication on the surface of the eye.
yeah, and that's pretty awesome. I mean, you're talking, 12 seconds, 10 seconds. So you're just
Mm-hmm.
showing how powerful this medication is.
Exactly.
Thanks for taking a deeper dive into that.
Of course.
Oh, actually, a comment just came in, not a question, but a comment about someone had great success for delayed epi healing by removing the bandage contact lens and old-fashioned pressure patching. Any thoughts?
Yeah, so I think that's a really, really good thought as well. With refractive surgery, the one thing that I am always concerned about is I don't want an infection to happen, especially when you have a significant corneal wound there. And I find that I myself get a little nervous when they're pressure patched because they can't tell me if their vision is being reduced. And so I like to have a bandage contact lens on there unless we're not getting the patient I have a patient who had an intolerance to a bandage contact lens. And so for that patient, I definitely pressure patched because I thought that was going to be the most comfortable way for that patient to heal. But we typically are using bandage contact lenses.
Well, in cases where it's not post-surgical, actually, Liz and I just talked about this at the last lecture we did in Virginia. is when it comes to some of the membranes,
Hmm.
you have to take the dry membrane, you put it in a contact lens, or you put it on the eye, then a contact lens, and maybe it slips out, then you got to refigure it all. And so what we're talking about, hey, why don't we just put this lens on the membrane on the eye, close that eye, and just pressure pass it down, and then bring them back in a few days, and then
Hmm.
we don't have to worry about those infiltrates, the sterile infiltrates that we see
Yep.
sometimes do the hypoxia of the contact lens and the membrane. And so, that's something that I'm going to start doing here.
Yeah.
One other comment I want to talk about is debridement. So we talk about that here in this case with some loose epithelium. We all see patients with recurrent corneal erosion, and all of us talk about debridement. For me, debridement is I'm taking my wax cells, so my little surgical sponge, whatever's loose, I clean up as much as needed. I don't take that whole cornea. I just take what's loose because and I always peel or I push toward the center because I don't want to go to the limbus. I mean, what are you all using whenever you're debriding? What area? I'm trying to keep it as little as possible for me.
I also am using a Wexel. I think that that's the tool that I found most effective to not take away too much tissue, because the Wexel will soften as the tears absorb into it. And so that's the tool that I'm using, but I'm exactly the same as you. I'm only going to try to take the cells that are sick so that we can try to leave that wound as small as possible. I never want to get into healthy cells if I don't have to.
You
Yeah, I'm
know,
the
well,
same way. I use a Wexel sponge, but I will warn them out there. I debride my EBMD patients, and usually that whole epithelial basement membrane. I remember doing my first one like 15 years. I still have video of it, removed like limbus to limbus on it. But in your cases here that you're talking about, you're going to have healed cornea, you're going to have some nice epithelium, so you're not going to be taking off. But I'll just warn the audience: in EBMD patients, you can get a significant amount of cornea
it
coming
it
off.
really does just come off, and it's always surprising about, you think that something looks healthy until you start debriding it and realize how much wasn't healthy.
well, you
Do-
mentioned using the dry membrane and a pressure patch. I like doing that myself. It's pretty firm, and even your most elderly patient can remove a patch themselves on a Sunday if they have to. So that's what I like about it. A question just came in. Can you discuss epithelial hyperplasia after PRK?
Walt, do you want to take that one?
Well, you can. It's totally fine since you actually do the PRK.
Okay, so when we're looking at epithelial hyperplasia post PRK, you know what I'm looking at is where it is on the eye, what it's looking like, how elevated is that area? Do I need to debride that tissue off again and try to allow new healing to happen? Those are all things that I'm going to consider, especially patient vision as well, how much the patient's vision is being impacted by it.
Yeah, for me, I tell the patient they need to be patient. At that
Hmm.
day 3, day 4, when you see that coalesced epithelium, I
Hmm.
want a central healing line, no infiltrates. I just say, hey, everything's heaping up in the middle. It's going to take time, and so be patient. Each week, it's going to get better and better. At 1 month, it should be gone, but at 2 months, I've had a couple patients. It took them a year for everything to fully settle down in their
Yeah.
eye. So that was a very rare case, but normally in a month or two, I just say, hey, this is a normal part of the healing, and I'll draw a little diagram for those patients and tell them exactly what's going on.
Yeah, and I will tell patients that their vision is always going to get worse before it gets better. So on day 2, when they're feeling pretty good, day 3, day 4 is when those cells have met in the middle and do form that epithelial healing line. And that can be almost cause like a diplopia and a monocular diplopia in the vision. And so that's a discussion that we're having pre-operatively, and then again at the 1 day post-op, so that they have that reminder. But typically, I'm not even telling my patients, like, we're not even going to assess your vision and be concerned about it until we at least get 1 month post-operative. Once we get 1 month, then we can start kind of focusing on your vision, looking at what that epithelium truly looks like, looking at how dry you still are, making evaluations at that point. But I'm really not concerned about it until we get, several weeks to even a couple of months out of surgery.
My tip to that would be I like to use my corneal topographer. They can understand red and different slopes and then
Mhm.
how it looks irregular. And if they come back 2 weeks later and I redo it and things are, the vision might be the same, but you get excited because it's starting to look more regular and they can kind of calm them down. So I kind of like to use the topographer on those cases.
Yeah. And you'll be able to see on your topographer, islands that you thought were going to be treated better than others. That's one of the things that a lot of times when we're having any type of post refractive surgery abnormality, the topographer is going to be your best tool as far as that so that you can compare those before and after topography images.
Yeah, we're not typically going to do a topography. It's about 3 months,
Hmm.
if they're not healing properly. I mean, but at the 1 week, 1 month, I mean, we're not even considering that. It's after that is when we need
Hmm.
all that information to look for stability.
Exactly. I
I
wouldn't
just I was just
expect.
going for the hyperplasia one. The patients that get concerned with it, their vision's down, whatever, especially if it's centrally. I just kind of walk them through it. I don't really need it other than this kind of they respond to pictures. That was just my little clinical pearl for that.
I agree. I think that patients always, when they can see what's going on in their eye, are going to understand it better. All right. So I think we're ready to go on to the next case unless there's any other questions that came in.
We're good.
Excellent. So this was a case, and we kind of have brought it up a little bit, but 40-year-old diabetic patient presents for a one-day post-op cataract for her right eye. Now, if we go back to Walt's case from earlier, the asymmetrical cataracts, that's exactly what this patient had as well. So she had developed this hyper mature cataract in her right eye, no history of trauma or anything that she was aware of, where really her left eye was doing pretty good. At that one day post-op, she was about hand motion, or pre-surgical findings, sorry, she was about hand motion 2 feet. And at her one day post-op, she had already improved to 20/40. So was doing really, really well, was feeling super confident and super happy with her vision. She had elected to do dropless medication with her cataract surgery. And so for those of you who have experience with dropless medication, this is just going to be an overview for you. We do it on quite a few of our patients. So we'll give them the options of whether they want to use a combination drop or whether that medication get injected into the eye at the time of surgery. So then they do not have to use medicated eye drops post-operatively. We find that that's really nice for patients who are in nursing homes or have really arthritic hands or nobody to help us or assist them with their drops at home during that 1 month post-operative period. But as with everything, there's pros and cons to everything. So when you're looking at dropless cataract surgery, obviously we don't have to worry about patient compliance that way. It can be at a decreased risk, especially when you're comparing it to branded drugs. Studies do show that there is a decrease in endophthalmitis using dropless versus using drops. And the really good factor about this is that there's no preservatives on that ocular surface. So if you have somebody who does have a preservative allergy or irritation, this could be a really good option for them. The cons with these, and the cons are definitely there, is when this medication gets put into the eye, I tell my patients it's going to look like ink blobs or a lava lamp floating through their vision for at least a week post-operatively. And that's something that we're discussing pre-operatively so that they're prepared for that, because it can be fairly alarming how big these floaters are. Also, there can still be some breakthrough inflammation, just like with patients who are on drops, that week 2, week 3, you feel like that inflammation still isn't super under control, so you keep them on the steroids a little bit longer. With these patients, you might still have breakthrough inflammation as well. And in those cases, you would also have to put on a topical steroid on those eyes too. It can be really difficult to control an IOP spike when the steroid is injected into the inside of the eye as well. So if this is a patient that you know has had an IOP spike in the past, it may be somebody that you want to dissuade from using dropless medication and just sticking with the typical drops to try to better control those IOP spikes. And there is some research or some evidence that says that potentially using dropless can increase the risk of toxic anterior segment syndrome. So for those of you who have not seen dropless medication before, I'm going to play these videos. This is from one of my patients, and what you'll see is kind of a posterior finding and an anterior finding there. With the posterior finding, you're going to see it look like these big white globs just kind of residing within the vitreous, floating around on the inside of the eye. We can see why patients would complain about that. When you're looking at them just at your 1 day post-op or 1 week post-op, you might see it as they look around, just fly across that pupil as just kind of a white film that flies across there. Typically, all of this will settle with the gravitational pull. So a lot of times we'll have our patients sleep slightly elevated for the first couple of nights post-surgery so that all of that medication settles to the bottom of the eye and that those floaters don't impact them as well. But it is definitely something that we're talking about with all of our patients pre-operatively. So she calls in, and I was the one on call this time, and she calls in, or her significant other calls in, about 10:15 at night. I have just taken my shower. I am ready to go to bed, and we get this phone call that says, my significant other had cataract surgery. Her eye over the past couple of hours has started to become incredibly blurry and incredibly painful. And those are really the two things that, looking at a post-cataract patient, those are the two things that I'm listening for, and those are the two things that I'm making sure that I get into the office for right away. If a patient is calling in, I just had surgery so many days ago and I'm having a lot of pain and a lot of blurriness, that is something that needs to be evaluated right now, not later. So I got to the office, met her and her significant other, and at that point she had decreased. So we're now talking about 2.5 days after surgery. She was 20/40 at her one day. She's now back to hand motion 3 feet. So I would say that's a pretty significant reduction in her vision. She did have some fibrin noted in her anterior chamber. She did not have a hypopyon at that point. The patient was in so much pain, she was rocking, holding her eye, rocking in her chair back and forth. She could not keep her eye open for me to even take a tono pen or an eye care tonometer to her to try to take pressure. She was actually moaning in pain. So what do we do at this point? And this is when you bring out your handy dandy little chart and say, okay, what do I think I have going on here? Do I think that this is a toxic anterior segment syndrome, or do I think that I have a true case of endophthalmitis happening? And when you look at hers, her timeline is a little funky. She really lies at about that rate right between the TAS, which is under 48-hour mark, and the endophthalmitis, which is most common, to 3 to 7 days. Typically, if we have any suspicion that it is an endophthalmitis, we are treating this as if it is endophthalmitis. And so we knew that she had the pain. We knew that she had the severe reduction in vision. She did have that fibrin present, which ultimately is more present with TAS, but she did have quite a significant anterior chamber reaction. But we were going to treat this as if it was an endophthalmitis. So when you're looking at endophthalmitis, very, very rare, up to 3 cases per 1,000 cases. But like we talked about, she did have that dropless medication. And if you look at the studies, studies show a 5 to 22 times decrease in endophthalmitis rates with dropless medication. But the rate of endophthalmitis is higher in diabetic patients than it is at the average population. And so our complicating factors were that with this patient was the ophthalmologist that did her surgery 2.5 days ago, his plane has just arrived to go skiing for his family's spring break in Denver. And our other ophthalmologist had just been taken to the hospital himself in a hypertensive crisis. So now what do we do for this patient? How do we treat this patient? Well, at this point at 10:15 at night, we know that she has to go to the emergency room. This is something that we need to try to get treated really, really quickly. And so I did call the ER and I said, we have this patient who I suspect has an endophthalmitis. I am sending her your way right now. And I did put her on an antibiotic eye drop. I gave her a sample from the office to start instilling into her eye every 30 minutes until she was seen at the ER. And so in a perfectly managed endophthalmitis case, what you're looking for is you're going to do some vitreous aspiration and a vitrectomy potentially for culturing, but you're going to be injecting these patients, or the ophthalmologist is going to be injecting these patients with 2 different antibiotics, typically vancomycin and ceftazidime, just so that they can get good gram-positive and gram-negative coverage. We were lucky in her case that she already had a lot of that antibiotic in her eye at the time. Fluoroquinolone was what we used with the dropless medication. At 10:15 at night, like I said, we're sending her to the emergency room so that she can try to get treated before morning. And when you're looking at endophthalmitis versus TAS treatment, they are going to differ quite a bit. So with endophthalmitis, you're going to be doing these intravitreal antibiotics. You're going to try to do a culture too, but you're not waiting to treat until you get those culture results back. Culture results can take, even up to a couple of weeks to come back. So this is somebody who's going to be treated right away, despite what that culture result says. There is some theory, and we're going to get to that study here in a second, about a vitrectomy. And some studies are even saying that it's the gold standard. But the theory behind that is if you can decrease the inflammation load within the vitreous, that helps the retina to not become so weakened in the periphery. Steroids we're also going to consider because inflammation plays a huge role in endophthalmitis cases, and then cycloplegic for comfort as well. Whereas if you compare that with TAS, you're really just going to be hammering those patients with steroids. We're talking difluprednate every hour, potentially even oral steroids, depending on how significant or how the severe case the case is, and looking for pressure spikes because of all of that steroid use. So potentially using some kind of glaucoma agent to control any pressure spike, and then cycloplegics in those patients as well. And so with this patient, she gets to the ER. She was never seen after the course of 8 hours, despite me calling, despite me asking for her to be seen. So I kept in contact with her all night. And at 7 a.m., when the retina office opened, I called the retina specialist who was able to see her at that time. She, or the retina specialist in our area, was able to get her in, was able to inject her by 10 a.m. So this was about 14 hours post her symptoms beginning. She was still in so much pain that even the retina specialist was only able to get one of the two medications in. And so he would have preferred to get both in, but he said, one is better than nothing. I'm going to see her back tomorrow. We're going to see how she's doing. And he wanted to continue on the moxifloxacin every hour, and then also gave her a prescription for that diproprednate to begin every hour as well. And so at our 1 week post-op, her vision was still about hand motion 2 feet, still fibrin present in that anterior chamber, which we hoped was really the significant reason for her visual acuity being so reduced. And we had no view to the retina because of that. She was going to continue her follow-ups with retina, and she was going to proceed with her left eye, but obviously we canceled that until we could know that the right eye was completely healed. So what could we have done differently with this case? I would hope that we all have an ophthalmologist who is available 24 hours a day, but in some cases that's just not the case. And so I think we did the right thing by sending the patient to the emergency room. I would still do the same thing. Unfortunately, the emergency room wasn't able to get her seen. Fortunately, our retina specialist was able to see her very early the next morning and be able to get her injected. When endophthalmitis care, we are on the clock. So the sooner that we can get this medication in, the better the patient outcome is. This patient actually did end up pretty well. At her 2-month post-op, she was about 20/40 vision, which is exactly what she was at her 1-day post-op, which we were really, really pleased with. And she obviously is thrilled with that too, because she started to count fingers before we took that cataract out. So she's one of the more success stories that I think we get to with endophthalmitis. But I think that takes us into our next polling question here. So what is the most common organism found in bacterial endophthalmitis? And we'll leave that question up here for a couple of minutes while we converse a little bit.
Yeah, Lindsey, did the culture come back positive in that case?
The culture actually did not come back positive in this patient's case. And
So
the retina,
is it still presumptive endophthalmitis, or you think it's toxicity?
it was as a presumptive endophthalmitis, but I am not convinced that it wasn't a TAS, especially with that timeline that was so, right kind of in the middle. I still would have treated the same way as an endophthalmitis, though.
Mm-hmm.
Yeah, that's hard to know without having those cultures in the end, because with TAS, you're going to see most of that inflammation that one day. They're not going to be in pain. They're going to be blurry.
Exactly.
So yeah, that's a tough one. But either way, I would have treated exactly the same.
Based on this patient's pain, I think it was pretty safe to assume that it was endophthalmitis. I have not had a TAS case that it showed up at our office in as significant pain as she was, but I have had other endophthalmitis patients who showed up with a significant amount of pain like she did. And so I think day in, day out, you're still going to treat this as an endophthalmitis regardless of what the culture says.
So you're getting the polling questions rolling in, and I think everyone's going with the obvious Staph aureus at 80% or 79%. But Staph epidermidis is at 13, Staph pneumonia is at 5, and then we have Haemophilus influenza at 2%. So I think we need to discuss this one a little bit.
Excellent. So when you look at the endophthalmitis vitrectomy study, what they found was that 69% of those patients with bacterial endophthalmitis were culture positive, and the vast majority of those were Staph epidermidis. And so I think that surprised me too when I first read this study, because I think I would have guessed the same answer as majority of the people kind of out in the poll. I would have said Staph aureus. We always hear about Staph aureus with all of these infections, but it's Staph epi that tends to be more culture positive when you're looking at endophthalmitis, which I think is really, really interesting. So I mentioned briefly the endophthalmitis vitrectomy study, and what this really looked at were patients who were presenting with endophthalmitis. They took their initial vision upon presentation, and then they took 2 different types of treatments: a pars plantar vitrectomy with intravitreal injection of antibiotics, and then a vitreous tap with injection of intravitreal antibiotics. And so what they found was those patients who were presenting hand motion vision or better performed better with that vitreous tap and intravitreal antibiotics. Those patients who presented with their endophthalmitis who were light perception or worse did better with that pars plana vitrectomy and then injection of intravitreal antibiotics. And so I think in her case, because she was presenting with hand motion vision, this was managed the appropriate way by not doing that pars plana vitrectomy and just doing that vitreal tap. And talking to the retina specialists in our area, this is what they're going off of when they're treating these endophthalmitis patients. And then when you look at comparative effectiveness of antibiotic prophylaxis and cataract surgery, what they're finding is that when you're using this dropless medication, adding an additional topical antibiotic doesn't prevent endophthalmitis more from just having the intracameral or intravitreal antibiotic there present as well. And so you don't have to do that topical antibiotic too. You can if you feel like the patient really needs it. I know I have a couple of patients who work in hospitals who prefer to also have a topical antibiotic as well, just because they're around different bugs and different things and they want that added benefit. But the study showed that it was not more effective as far as preventing endophthalmitis.
Yeah, based on that study, we always do intracameral moxie in our patients, but we still give them the topical antibiotic combination drop just because they're used to giving combination drops.
Yeah, absolutely.
So what I've learned from being around hospitals is that if it's a device, it's usually staph epi, and then if it's just kind of a general, like catheters and things like that, implants, knee implants, staph epi, and then if it's just an infection, usually staph aureus. If there's any boards questions out there, that would be how I would answer.
Yeah, exactly. So here's another case, and we often hear about the infections in front of the eye, but what if this was the back of the eye? And so patient called evaluation for fog-like vision and increased floaters since an intravitreal injection of anti-VEGF two days prior. You can see the history, wet AMD, and you can see the medications that they're on that I should have put generic names on everything. Next slide. And so came in 2020 and the vision was 20/60 best corrected with pinhole. It was slightly better before that. But here you can see the findings better in my typed up words. Trace injection, fine KP with trace edema, 3+ cells, anterior chamber lens is in good position, but also 2+ cells in the posterior chamber. And so, yes, we always know if we see the anterior chamber reaction, we're thinking, oh, it's inflammation. But whenever we're looking at uveitis, the more posterior the inflammation is, we have to have a higher suspicion of an infectious etiology. And so, next slide. And so the diagnosis for the patient was also acute postoperative endophthalmitis, and we already went over the various aureus and epidermidis. Even though it's very rare, it does happen after intravitreal injections. And I joke around that some patients go, "Hey, that the retina doc, he's not very talkative, he's not very personable." But one of the things each time they're doing the injection, they're spitting, right? Everyone talking, there's stuff coming out. They just want to be as aseptic as possible, doing their betadine wash as well for those patients and doing their injection. Next slide. And so the workup is going to be the complete ocular history. If you can't see the retina, always consider a B scan to establish what's going on in the back of the eye. May need to do the culture and sensitivity studies, as Lindsey just mentioned earlier. And then, whether the procedure is going to be a tap with the various antibiotics or a pars plana vitrectomy. Next slide. And so once again, this can happen after the intravitreal injections. And so if this happens, we're still going to do the antibiotics intravitreally. We're going to do the topical steroids because there's inflammation. Any pain that may occur, atropine, Lindsey mentioned any of the cycloplegics for the patients. But typically oral or IV antibiotics aren't typically used. Sometimes we may need an oral antibiotic in these cases. Next slide. But what I want to get to is the role of antibiotics. And so, yeah, I mean, our surgeons are doing injections, monthly or, with some of the newer ones, bi-monthly or even spread out even after that. But antibiotic resistance does occur on the ocular surface with repeated use of topical antibiotics. And so there was a study from Yin several years ago. There was also a study and a poster presented at ARVO where they looked at, there was about 5,800 patients, and what they found is the pre and post-operative antibiotics provide no benefit of reducing endophthalmitis for those patients. And so, based on these studies, that's why, they're looking at how they're prepping the patient with the betadine versus using the antibiotics pre and post-op next or post-procedure. And so if they have this, they're going to do the treatment, the intravitreal antibiotics, monitor within the next day, typically, relief of pain. Anytime, whether it's a corneal ulcer, whether it's endophthalmitis, if we do our treatment and the pain is getting better, we know that we're getting control of the microorganism. I mean, it's not going to change our follow-up, but it is always a good sign that the patient is improving. If the patient's responding well, topical antibiotics may be slowly tapered after a couple of days. Fortunately, though, endophthalmitis after intravitreal injections is going to be very rare. But just want to bring up those studies just to talk about that. But that's pretty much what that case is about.
All right. So I think I'm going to get into case number 5 here. 72-year-old male presents for a cataract pre-op, and he complains of all the things that our typical cataract patients are going to complain out of. He did glare quite significantly, and we noticed that he had about 3+ changes in his lenses in both eyes. Posterior segment was within normal limits in both eyes. And so when we're looking at all of his preoperative scans, one of the things that we're always doing preoperatively is a scan of the macula and the scan of the optic nerves. Number one, because we want to make sure that we're not missing anything on the inside of the eye. But number two, it gives us a baseline that if something changes post-operatively, we can come back and look at this and we can reevaluate and we can see what has changed on the inside of the eye if we have that evidence. We're also looking at higher order aberrations too. So when you're looking at recommending different lens types for patients, one of the things that I think we need to be considering is what amount of higher order aberrations that they have. And when you look at studies, it's actually pretty difficult to find studies that support how much of a higher order aberration should we not recommend a multifocal IOL for. But there are some studies that say if they have more than 0.32 diopters of higher order aberrations, that may be somebody that's not a candidate for a multifocal or for a premium IOL. And so his higher order aberrations were below that point. We look at his corneal sill and we find that he has about a diopter and a half, diopter of quarter in both eyes. And so now we kind of know what way to lead that conversation as far as what IOLs to recommend for that patient. And so the patient decided he did want to proceed with a trifocal IOL and that he did want to proceed with dropless medication first. And so we were going to do the right eye first, left eye to follow a couple weeks later. And so when you look at his post-operative visits there, you can see that these are fairly standard post-operative visits. The right eye started at about 20/50. By 1 month, he's 20/20. Left eye started at 1 day at 20/20 vision, and at 1 month, he's now 20/40. And so when I'm seeing a decrease in the vision like this, from the 1 day to the 1 week to the 1 month, this is when I think that we need to be stepping in and figuring out, okay, what's going on with the eye? Why did you see better at your 1 week post-op versus what you're seeing at the 1 month post-op? Because things should only have improved between that time and now. And so when we look at him, what we found was that he had a partial macula on detachment. So he had about half of his macula hanging on for dear life there. And so obviously we were going to have an immediate referral to retina specialists because of that. But this is one of those things that can happen. Approximately 1 in every 500 cataract surgeries in patients over the age of 40 within 1 year of surgery are going to have a retinal detachment from having this intraocular surgery. There is thought a possible increase with dropless cataract surgery, so that's something to consider as well. And where that becomes problematic is, like I was discussing before, these patients are already going to have an increase in floaters because of that medication floating in the inside of the eye. So really what we're telling these patients in their post-operative period is that your floaters should be getting better. They shouldn't be staying the same. They shouldn't be getting worse. If they're staying the same or getting worse, that is something that we need to know about before your 1 month post-op, so we can differentiate just that dropless medication floating in the inside of the eye versus a retinal tear or retinal detachment that's developing on the inside of the eye there. And so 1 month post-op vitrectomy with retina repair, he's about 20/50 plus. Posterior segment, he did have some hemorrhaging around that retinal scarring, and he was developing a little bit of an epiretinal membrane, as so many of our retinal detachment patients do. But really, I think what we need to be remembering and what we really need to be talking about with patients is how long the process is when you're talking about a retinal repair. So if we look at his macula from before surgery, from 1 month repair to 3 month repair, you can see how much even that little bit of edema on the far side of the macula there has gone down just within that 2.5 month time period. And so making sure that patients understand that this is a game of patience, that this is going to take a little while, especially with those patients who, unfortunately, this gentleman had that trifocal IOL. He was so excited to be able to use that and be able to have vision at all these different distances. Now his healing time has been delayed because of all of this. And so when you're looking at a retinal repair, that can really take up to an entire year to heal, and that's a conversation that I'm having with these patients. But also evaluating, and when you're recommending premium IOLs, should we be doing these patients who are high risk or have different intraocular conditions that may predispose them to not seeing as well out of those IOLs? I think we need to really be considering who is a very good candidate for these types of patients. And then also looking at traditional drops versus dropless. Is this a patient who has had previous retinal injury before? Probably not a patient that you want to recommend dropless cataract surgery for. Is this a glaucoma patient who we know has fragile visual fields or fragile pressures? Probably not someone we want to put dropless medication in. Is this a patient who is a diabetic? We want to make sure that that patient is probably on an NSAID so that we can try to control the risk of cystoid macular edema happening afterwards. And so taking all of those things into consideration.
So, hey, Lindsey, on this case,
Yeah.
what was his refractive error from the beginning? Did he have those risk factors? I can't remember.
He really did not have any of those risk factors. He was not a high myope. He was, if I'm remembering correctly, about a -150. And so he didn't have a increased axial length. He was fairly standard across the board there.
Okay. Okay. Anytime you have a question, let's say it is a high myope, one thing that we always do is we just have them see retina first.
Mhm.
We're happy to do it. Go get the retina clearance first. That way we took every single precaution for those patients. But I mean, if this one's a -1, I mean, part of your IOL package, you have those OCTs in there.
Yep.
You have everything. And so I mean, you did all the due diligence to optimize our outcomes. But unfortunately, there is always a risk. Cataract surgery is real surgery. There's always risk. And unfortunately, that happened with this
And I
patient.
think that's kind of the main summary of this entire presentation is even when you do all the things right, you can still have complications with your patients. And how do we address and manage those patients to make sure that their outcome is still successful? All right, I think this one's you, Walt.
Sounds good. Any questions, comments, Greg, Joe? You want to keep going?
No, we're
Right.
good. We
All
probably
right.
I think we have time to delve into this case.
Yep. All right, PK problem. So 47-year-old white male presents with blurry vision in the left eye for the past couple months, denies any eye pain, was on prednisolone at least once or twice a day, whatever he felt like that day. So that means there's many days he didn't do any of the drops. Ocular history, had a PK at 98. I saw this patient a couple years ago. And localized vascularization of the cornea in the left eye. And so we did an anti-VEGF injection and argon laser to address that vascularization onto the cornea. Next slide. And so when we look, the right eye, everything was normal, history of keratoconus with a scleral lens in place. But the left eye, counting fingers, white quiet, 1+ peripheral haze, and it didn't come out in this picture, so I scribbled it on there for you all. 1+ diffuse SPK, the scattered vessels, central epitheliopathy, but had no KPs, deep and quiet, and the pressure was 45. And so, we did this surgery over 20 years ago, 20+ years ago. And, we've been seeing this patient, anytime we do a transplant on that patient, we're seeing every 4 to 6 months, monitoring those patients. We have them on steroids for graft rejection, but we know that we have to watch their pressures. And so we're monitoring the pressures for glaucoma as well. So next slide, the question is, what's going on with this patient? Is he a steroid responder? He's been on steroids for over 20 years. So is that the case? Does this patient have angle closure glaucoma? As I showed in the last slide, the anterior chamber was deep and quiet. We know with angle closure, we're going to have, narrow angles. We're going to have, a mid-dilated pupil. We're going to have cloudy cornea. We had some cloudiness in the cornea, but the angles were open. Herpes simplex, if it doesn't make sense, herpes simplex always comes into our differential. But any herpes simplex or herpes zoster, you can have a trabeculitis, which is a type 3 hypersensitivity response that can cause increase in inflammation within that cornea and lead to that steamy cornea, but also cause the inflammation of the trabecular meshwork to lead to the high pressures. And so, what else could be something that I didn't even think of? Who knows? So next slide. So we went with herpes stromal keratitis, and so I put the patient on valacyclovir 500 milligrams 3 times a day. Prednisolone was on it once or twice a day. We bumped it up to 4 times a day. Why? Because it's an inflammatory response. I did sodium chloride twice a day to address any of the inflammation. It said, hey, come back in 3 days. And so treating the infectious or the inflammatory reaction due to the herpes infection. So bring the patient back on the next slide. And the pressure was exactly not the same. It was actually higher. So took a look, did Pachy on the patient, did everything we can to lower that pressure. And so anytime you have high pressures, yes, typically we're always been taught, put in the timolol, do the bromonidine. We're trying to do anything we can to get this pressure lower. And so even with the oral acetazolamide, got the patient pressures down to about 29. Had them continue the valacyclovir 3 times a day, sodium chloride, but decrease the steroid to twice a day, and then added in the glaucoma drops, as you can see there, and then said, well, let's follow up in a few days and schedule an SLT. We didn't do the SLT right away because it takes, about 4 to 6 weeks to get that pressure to go down. And so that's not going to be an effective option for our patients. And so we're going to do it, but it's not an emergency right away. Next slide. And so, then the patient comes back and the pressure's lower. And so they did respond to the anti-glaucoma medication. Cornea is clear. You see the plan there, kept them on the steroids and kept them on the glaucoma agents and said, come back in a week after that. And so the question that we had here, we have the OCTs on the next slide, and never do the red, yellow, green disease. And on the bottom left, you can see there is a decrease in the neurofiber layer for that patient. So you go to the next slide. And so the biggest question there is, was this a stromal keratitis? And that's what we initially thought, because that pressure went up right away. And so patients been on steroids over the years. That's why we're like, it can't be a steroid response. And we're all familiar with herpes. And so this will be in your notes. Next slide. And so the herpetic eye disease study, a couple of call outs here. If the patient has stromal keratitis on steroids, there's no apparent benefit in the addition of oral acyclovir to the treatment of a topical steroid and topical antiviral. And so essentially you can use the steroid and the topical or oral antiviral. I know some of us do both for patients just to fully control the infection, but this study shows you can do either. Benefit of using oral antivirals or with patients receiving topical steroids for any type of iridocyclitis. But next slide. But acyclovir prevention, anytime you have that patient with a history of herpes, and it doesn't have to be this case, it does reduce by 41% the probability of recurrence, but 50% reduction of the more severe form, which is going to be the keratouveitis or the stromal keratitis. And so next slide. So was it herpes or was it steroid-induced glaucoma? And so post-PK glaucoma, it can maybe relate to the collapse of the trabecular meshwork. Here's some studies. Franca's study shows that about 21% of patients develop glaucoma after penetrating keratoplasty. Pramnik, in their study on bottom there, reported steroid-induced glaucoma in about 3.6 patients after about 13.8 years. And so, yes, they've been on steroids for quite some time. And so who knows? What was it? That remains to be seen. In the end, this patient likely had the steroid-induced glaucoma even after 20 years. That is the reason why we watch these patients over time, because there's always a risk of them developing a steroid response. And so That's what I got for that case.
All right. I think we've got time for at least this one. So patient of mine, 68-year-old female, presents for a 1-day post-op. And I think this is one of the most common post-operative complications that we're going to see. Vision is about 20/50. She's got 3+ stromal and microcystic edema noted with about a 2+ AC reaction, and her IOP is 45. And so we get this IOP spike at the 1-day post-op. This is why our office is still seeing our 1-day post-op, so that we can try to manage them. But what do we do now? How do we manage this? And so, like I said, this is the most common complication of cataract surgery. And typically it's just because of that retained viscoelastic that clogs up that trabecular meshwork. And there's thought that as many as 18 to 45% of patients experience this pressure greater than 28 following cataract surgery, but that it returns most oftentimes back to normal within that 24-hour period. So you may have a patient that you're seeing back for a 1-day post-op that their pressure spiked at some point during that 24-hour period, but it's now returned back to normal as that trabecular meshwork has returned back to normal as well. We tend to see that increased corneal edema secondary to that increased IOP. So as soon as we reduce the IOP, that corneal edema does tend to resolve as well and increases the visual potential for that patient. And so when we're looking at patients who might be at higher risk for having an IOP spike, obviously it's going to be your pre-existing glaucoma patients, potentially even your high myopic patients, difficult surgical patients, or patients that had shorter eyes where they had to use a lot of viscoelastic. Those patients are potentially going to be at higher risk for having an IOP spike as well. And then obviously your steroid responders as well. So when we're looking at these patients, the drops that we're going to use, typically we'll have our technician put a drop in as soon as that pressure is checked. They're going to use bromonidine, and then we potentially will add timolol to that, seeing how they're doing. For orals, you can consider acetazolamide, 250 to 500 milligrams. You want to make sure that you're not getting the extended release tablets. We have a bottle of these that we keep in our office, that if a patient is having a pressure that's just not budging, we will go get a couple tablets from our cabinet and give them to the patient while they're here, and then check their pressure about 30 to 40 minutes later to see how that pressure has decreased after the taking of that medication, and then potentially even burping the wound. So when we're burping the wound, we have to remember that it does increase the risk of endophthalmitis. So we're really going to save these for patients who have pressures who are higher than 40, that are not responding to those orals and not responding to the drops that you've already previously done while they're in office. And then you're also going to consider this for patients who do have fragile visual field. So if you have a severe glaucoma patient, they're presenting to you with a really, really high pressure at that 1-day post-op, you may want to burp that patient sooner than you would the average person. And so when we're looking at burping a wound, this is kind of like a step-by-step process. And we're going to talk about it here because I have a video, but we're going to numb the eye first. And then I typically am doing that with fluorescein because that helps to stain the wound, so I know where to press. And then we're also instilling a drop of antibiotic a couple minutes after that fluorescein, or a couple seconds after that fluorescein, to help just get some fluoroquinolone on the surface of the eye too, to try to decrease the risk of endophthalmitis. Stabilizing the patient, I think, is really important, because the worst thing that a patient can do is not have their forehead completely on that strap, and then you go to press, and then that's the time that they decide to move their head forward. And so you want to make sure that you're either having your technician or somebody hold their head up to the microscope as you're doing this, so that you can make sure that you're putting a right amount of pressure on the eye. And then you're going to find your sterile instrument. And everybody here at my office uses something different. I tend to like to either use a sterile cotton tip or a sterile Wexel when I'm doing this. And when I say sterile, I am talking about a sealed package that has not been opened, because we know those Wexels will typically come 6 in a package. I want a brand new package that I am physically opening in the exam room with this patient. And then we're going to apply a very small pressure to the outside edge of that wound. And you're going to want to be prepared for that aqueous to move fast. The higher that the pressure is, the more aqueous that's going to come out as soon as you press it. And we're just going to continue to check that pressure until it's to our desired result there. Typically, I'm wanting somewhere in the teens. And then once I have it there, I'm going to put another drop of fluoroquinolone in. And so I have a video here. This is actually from a patient that I've seen, just saw a couple of weeks ago. With her, you can see I already put the fluorescein and the antibiotic in the eye. I've used a cotton tip for this patient. I'm going to gently press, but you can see how much aqueous comes out just with that small press. And so, like I said, be prepared for that to happen. The higher the pressure, the more the aqueous is going to want to flow out there.
But
And
Lindsay,
so
if that pressure was 48, then what you just did there, I bet you that pressure is still 42, right? I think
yes, exactly.
you
And so this may take a couple of presses to get on the surface of the eye. And that's what you're going to see is when I did the burping on this patient, we did the drops, we did the orals. I pressed one time, it went from 44 to 34. I pressed again, it took it down to 19. And so don't be afraid to give it another press, especially once you've reevaluated that pressure and you said, okay, this is how much fluid came out and this is what it decreased the pressure to. I knew that with that first press, it decreased it by about 10 points. So I could either press a little bit more firmly to get a little bit more fluid out, but that's going to give you a good assessment on kind of where you need to go as far as that next burping of the wound.
Yeah, so
And so
the clinical pearl for the audience is when you do it for your first time, you're under 60, whatever, 30 magnification, 40 magnification, 20 magnification.
yep,
When you push, it's going to look like you just took down to 0. That pressure's
exactly.
still going to be high. You're
It
going
will
to get
be.
a feel for it, how to feel it. You can actually just do finger tension too on it, just have them close their eyelid, and you can just kind of feel how soft that eye is. I like getting them down to about 10, then I know that they're going to drift up to be,
Yep.
probably in that 20 range, and then they're pretty safe. So,
All right, let's be honest. Who got it to 0?
Oh, I've got it to 1 before, which is probably a 0.
Yeah.
I've got
um,
iris. I told you I got iris capture in mine. So that was, that was a patient on Flomax, but I'm not proud of that. It's just, that was
yeah.
part of that communication talk. So.
The reason why I brought that up is, yes, you may get it low like the first couple times you do it, but just do a little bit at a time. As Lindsey just mentioned, you can press on that again. Even if it goes down, it's going to go back up within 2 hours. Hildebrand did a study that even after this orbital decompression, that pressure is going to go up. That's why you always have to check the pressure. Lindsey's going to talk here about keeping that patient on a glaucoma agent to make sure that pressure stays down.
Yeah.
So are you always burping the main incision or the?
So our surgeon only does one incision. So we don't have a choice on what incision to use because he does everything through one incision and that's the incision that we're using. For
Okay.
surgeons that use the 2 incisions, I typically recommend to use the smaller incision of the 2.
Okay.
The burp and the paracentesis. And well, you talked about, so those that are out there, you kind of have to know how your surgeon sits. So when I worked in a surgical practice, I had a surgeon that sat temporally. So he sat by the ear and
Mhm.
sat by the ear. The one sat at the top, one was left-handed and one was right-handed. So I always kind of had to figure out who was doing the surgery and where they were sitting. So where I could find the paracentesis compared to the main wound. So those that are out there, you kind of have to know which handed your surgeon is. But Lindsey said you could put the stain in there, kind of find it, but it makes it a little bit easier whenever you're looking all around that eye, which could be beat up from all the, the drops of the day before. So
So for this case,
another real quick pearl that I'll
yeah.
give is that I always like to use like TrueSoft or a CoSoft or like an Combigan, and I'll use a QID in that eye. Everyone goes, "Oh my gosh, you're using a QID." Well, I'm like, well, if you use a BID, it's still 4 drops. I'm just using it all in one eye for that day, so I'll use CoSoft or Combigan, just QID in the one eye.
And that's exactly what we did with this patient was we put them on bromonidine timolol. We kept them on it. We saw the patient back the next day. At the next day visit, her pressure was 17. At this point, I would expect the eye to have dispelled that viscoelastic a lot more. And so, and the corneal edema, everything was looking better. Vision was improved as well. And so because we got that pressure down, her vision was able to improve at that point. And then we were just going to see her back at her regular 1-week post-op at that time.
I will tell you that I do something I do something a bit different. I don't burp. I've never felt the need to it. I get the pressure spikes in the 50s. We have loose Diamox in the office. I'll give them 2 tablets in the office. I'll give them some more to take at dinner, at breakfast. So I'll give them like 6 tablets altogether. And I like to have them COSOP PF in the office because I can just tear off a couple little vials. And I can tell you, I've never had a situation where they came back the next day where they weren't under 20.
Yeah. And I think that's a perfectly reasonable way to manage this case too. I know we have a retina specialist in the area who will never burp a patient ever. And so they she refuses to burp patients just because of that risk of endophthalmitis. And so I do think it's important to remember that anytime you're opening any wound on the surface of the eye, you're introducing or allowing for bacterial presence there as well. And so I think that's a really safe way to keep your patient from, unfortunately, getting a case of endophthalmitis.
Yeah, as I like to say, Diamox never caused endophthalmitis. So I think before if you're going to go on, we're really at our time now. So I think we want to do some final wrap up here. We are caught up on the questions from the audience, so we're good there.
Excellent.
Yeah. So however you and Walt want to wrap her up, and then I'll do some of the housekeeping.
All right. Well, I think that pretty much wraps it up for me as far as all the cases that I wanted to talk about. I'm happy to stay on for, any questions that might come in afterwards. Walt, anything you have left to say?
Yeah, if you can leave it to our last slide there. I mean, communication, that's going to be the key to any relationship with the patient, with the provider, with other colleagues as well. I know a lot of things we're talking about here is MD-OD type co-management and collaboration, but we do need to utilize colleagues as well and do OD to OD. If you live in Oklahoma and don't have a laser, refer it to Lindsey, and Lindsey can do a laser. If you don't have certain types of technology, if you need an OCT, you can refer it to an OD. It doesn't have to be, but here we're talking mostly surgical cases, and so we do want to make sure we're communicating with the surgeon. But don't forget intraoptometric co-management. So our emails were up there as well. If not, get them from Greg and Joe. And thank you so much for being here and for having us here.
And thank you. Thank you so much for having us.
Oh, thank you. We really appreciate it. It was engaging and fascinating.
So while we're getting to the last slide here, if everyone looks at their screen that's out there right by survey, you'll see this little red dot. If you want to click that, you won't have to wait till 9:30 to get that post-event email. And then Joe, I'll have you look one more time at that chat box. Make sure that there's no questions in there.
We're good.
All right. And so Lindsey and then Walt, I certainly want to, thank you for, doing this. Obviously, I worked in an ODMD practice for years. I have a surgeon that comes into my practice. Doing post-op care is certainly within the realm. And then this was a fantastic, as Joe said, a fantastic lecture that you guys did. So thanks for doing this for us.
Thank you so much.
And you are getting your virtual round of applause from the audience. Everybody's thanking you for a wonderful presentation.
Well, we thank you all for being here.
So with that being said, that will conclude the education for tonight. And I'd like to thank everyone for attending.